Cardiac tamponade is a life-threatening condition characterized by excessive fluid accumulation in the pericardial sac. The excess fluid exerts pressure on the heart and decreases the filling of the cardiac chambers, eventually reducing cardiac output. Patients with cardiac tamponade are typically hemodynamically unstable and may quickly develop cardiovascular collapse and cardiac arrest, so they require prompt recognition and treatment with emergent drainage of the pericardial fluid to restore cardiac output. Cardiac tamponade can occur due to bleeding, which is also known as hemopericardium, which typically occurs as a result of chest trauma, aortic dissection, left ventricular free wall rupture, or iatrogenic as a result of medical intervention. Cardiac tamponade can also occur due to effusive constrictive pericarditis, often as a result of infection, uremia, or malignancy. Now, if an individual presents with signs or symptoms of cardiac tamponade, you should first perform an ABCDE assessment. These individuals are typically unstable, so immediately stabilize their airway, breathing, and circulation. Next, obtain IV access. Put your patient on continuous cardiac and vital sign monitoring and provide supplemental oxygen if needed. Now, here's a clinical pearl to keep in mind. Cardiac tamponade is associated with decreased cardiac filling that can result in obstructive shock. So be careful with the administration of IV fluids, since an excess of fluid could increase cardiac preload. In the setting of cardiac tamponade, where the cardiac filling is already impaired, an increase in the preload can potentially precipitate cardiovascular collapse. Similarly, mechanical ventilation can increase intrathoracic pressure, causing further impairment to venous return and cardiac output. Therefore, it's best to avoid or delay it whenever possible. Next, you should obtain a focused history and physical exam. History usually includes chest pain and shortness of breath. The physical exam may show tachycardia. A classic finding is Beck triad, which consists of hypotension, muffled heart sounds, and jugular venous distension, or JVD. You may also observe the Kussmaul sign, where JVD worsens during inspiration due to a rise in jugular venous pressure. Lastly, some patients may show pulsus paradoxus, which is a drop in systolic blood pressure of 10 millimeters of mercury or more during inspiration. Keep in mind, though, that pulsus paradoxus might be absent in patients with atrial septal defect, aortic regurgitation, elevated diastolic pressures, or pulmonary hypertension. If your patient presents with these signs and symptoms, you should suspect cardiac tamponade. Next, order a 12-lead ECG, chest X-ray, and bedside echocardiogram. The ECG usually shows sinus tachycardia, and you might also see a decreased QRS amplitude. In severe cases, you may notice electrical alternans, which is a beat-to-beat variation in QRS amplitude that occurs as the heart swings anteriorly and posteriorly within the enlarged pericardial sac, varying the relative distance from the ECG leads on the anterior chest wall to the heart. Chest X-ray typically demonstrates the water bottle sign, which is an enlargement of the cardiac silhouette in the shape of a water bottle. Finally, echocardiogram reveals pericardial effusion, collapse of the right atrium during ventricular systole, collapse of the right ventricle during ventricular diastole, and a dilated inferior vena cava. All of these findings help confirm the diagnosis of cardiac tamponade. Now that you've confirmed your diagnosis, proceed with an emergent percutaneous pericardiocentesis to relieve the pericardial pressure. Ideally, for optimal results, percutaneous pericardiocentesis is performed under ultrasound guidance. If ultrasound isn't readily available, pericardiocentesis can be performed using a blind approach. However, keep in mind there's a higher risk of complications, such as pneumothorax and myocardial perforation. The procedure involves inserting a needle through the chest wall into the pericardial space to drain the excess fluid. Even just a few milliliters of fluid removal can improve cardiac function. After the pericardial fluid has been aspirated, a catheter can be left in place in order to allow further drainage and prevent reaccumulation of the effusion. Also, be sure to collect a sample of pericardial fluid for visual assessment and lab analysis. Now that the pericardium has been decompressed, perform a visual assessment of the collected fluid for the presence of blood. If the pericardial fluid is grossly bloody, you're dealing with a hemopericardium. Your next step is to revisit the history and physical exam findings to determine the underlying cause. History might reveal previous trauma to the chest wall, such as blunt trauma from a motor vehicle accident. On physical exam, you could see an open chest wound, such as a stab wound or a flail chest. If this is the case, the hemopericardium was probably caused by the chest trauma, so you should consult the surgical team. On the other hand, if your patient presents with acute tearing chest pain and on the physical exam you notice weak peripheral pulses, suspect aortic dissection and consult the surgical team. Now, let's say your patient has a history of recent myocardial infarction, and the physical exam reveals a new holosystolic murmur. In this case, suspect a left ventricular free wall rupture and again consult the surgical team. Finally, if your patient had a recent cardiac procedure like pacemaker lead placement or coronary angioplasty, suspect iatrogenic hemopericardium and again consult the surgical team. Now, here's a clinical pearl to keep in mind. During coronary angioplasty, a balloon is inflated in the lumen of the coronary artery to displace an obstructive plaque which can cause a coronary artery to rupture. Likewise, since pacemaker leads are often placed directly into the ventricular myocardium, they pose a risk of myocardial perforation if the lead is placed too deep. In either case, blood can enter the pericardial sac and cause cardiac tamponade. Alright, now let's go back to the visual assessment and discuss situations where pericardial fluid is not grossly bloody. In this case, diagnose effusive constrictive pericarditis and send the fluid to the lab for cytology and culture. First, let's say that your patient reports fever and chills. The pericardial fluid appears cloudy or purulent, and cytology reveals a high white blood cell count. In this case, you should suspect an infection and start empiric antibiotics against the most common bacterial agents, including Streptococcus pneumoniae and Staphylococcus aureus. Next, assess culture results. If the pathogen is identified, diagnose bacterial pericarditis, so don't forget to tailor antibiotics based on results and start your patient on anti-inflammatory medications such as NSAIDs and colchicine. However, more commonly, your results will come back negative, so you should suspect viral pericarditis, which can be primarily caused by coccidioviruses, HIV, and influenza. In this case, just start your patient on anti-inflammatory medications like NSAIDs and colchicine. Next, let's say your patient has end-stage renal disease or ESRD and has missed dialysis. In this case, the physical exam might reveal a frosty or velvety appearance of their skin, and the pericardial fluid could show mononuclear cells on cytology. These findings are highly suggestive of uremic pericarditis, which might require urgent hemodialysis to remove the excess urea from their blood. Finally, your patient might report a history of a known malignancy, typically lung cancer, or unintentional weight loss. If the cytology reveals malignant cells, you can diagnose malignancy. The next step is to perform a workup to identify the primary origin of the malignancy if not known. Also, consider consulting the surgical team. One last clinical pearl: autoimmune conditions such as systemic lupus erythematosus, rheumatoid arthritis, and Sjogren's syndrome can also cause effusive constrictive pericarditis and lead to cardiac tamponade. After stabilization, treatment focuses on controlling the underlying disease. Recurrent cases may require more targeted management and surgical consultation for pericardectomy. All right, as a quick recap, cardiac tamponade is a life-threatening condition characterized by excessive fluid accumulation within the pericardial space. These patients are unstable and require emergent management, followed by focused history and physical, ECG, CXR, and echocardiogram. Once you diagnose cardiac tamponade, perform an emergent percutaneous pericardiocentesis and assess the pericardial fluid. If the fluid is grossly bloody, that's hemopericardium, which requires surgical consultation. On the other hand, if the pericardial fluid is not grossly bloody, diagnose effusive constrictive pericarditis and send fluid to the lab for cytology and culture. If you suspect an infection, start empiric antibiotics until you get culture results that can either help you tailor or taper off antibiotics. Patients with ESRD that missed dialysis can develop uremic pericarditis, which may require urgent hemodialysis. Finally, if pericardial fluid analysis reveals malignant cells, you will want to look for the primary malignancy and consider surgical consultation.
Cardiac tamponade can be broken down. Tamponade refers to pressure, which obstructs blood flow, and cardiac refers to the heart. So in cardiac tamponade, there's a buildup of fluid in the pericardium, and that fluid puts pressure on the outside of the heart. As a result, the heart's unable to pump normally and blood flow is obstructed. Normally, the heart sits inside the pericardium, which is a pouch or cavity with two layers. The outer layer is the fibrous pericardium, and it helps keep the heart in place within the chest cavity. The inner layer of the pouch is the serous pericardium, and that includes the pericardial cavity, and is filled with a small amount of fluid that lets the heart slip around as it beats. The cells of the serous pericardium secrete and reabsorb the fluid, so usually there's no more than 50 milliliters of fluid in the pericardial cavity at any time. That's about as much as a big shot glass. A pericardial effusion is when the fluid starts to pool in the pericardial space, and it can develop into cardiac tamponade, depending on how much fluid there is and how quickly it accumulates. A rapid accumulation of fluid can happen as a result of trauma to the chest. For example, a stab wound can puncture a blood vessel and fill the pericardium with blood. Even blunt trauma, like a steering wheel getting pushed into your chest during a car crash, can lead to tamponade, because the force of the impact causes the rupture of lots of small blood vessels. Cardiac tamponade can classically happen a few days after a myocardial infarction, because the weak, infarcted ventricular wall ruptures when it's exposed to high ventricular pressures. A rare cause is heart surgery, where once again a weakened muscle can rupture and cause cardiac tamponade, days after the operation. Yet another cause is aortic dissection, which is when blood pools in the actual wall of the aorta. If the aortic dissection ruptures through the wall of the aorta and through the fibrous pericardium, blood can spill right into the pericardial cavity, leading to cardiac tamponade. In these rapid situations, even a small volume, as little as 150 milliliters, can lead to tamponade, because the pericardium doesn't have time to stretch and accommodate it. Other causes of cardiac tamponade typically happen over long periods of time, and in these cases the fluid comes from a chronically inflamed serous pericardium that can't reabsorb pericardial fluid as quickly as it builds up. This includes cancers that have spread to the pericardium, often from the lung and the breast. Another cause is uremic pericarditis, where blood levels of urea, which is a nitrogen waste product, get really high, usually due to a kidney problem. The high levels of urea irritate the serous pericardium. More rarely, cardiac tamponade can happen because of hypothyroidism, or because of chronic inflammation from a connective tissue disease. In these situations, when fluid accumulates gradually, the pericardium can hold as much as 1.5 liters of fluid before tamponade sets in. So tamponade means that fluid puts pressure on the heart itself, preventing it from fully stretching out or relaxing between contractions. This means that cardiac chambers can't fill with blood properly, and this causes a decrease in cardiac output or a lower amount of blood being squeezed out with each heartbeat, which leads to hypotension. Less blood leaving the heart also means less blood reaches the organs and tissues, and the heart tries to compensate for its low output by beating faster. When a person suffering from cardiac tamponade inhales, the systolic blood pressure sometimes drops. Normally, breathing in creates a tiny bit of negative pressure, which pulls blood into the heart, momentarily increasing systemic venous return. When that happens, the right heart volume increases, and the right ventricle expands a bit into the pericardial space, so it doesn't affect the left heart volume at all. In cardiac tamponade, during inspiration, the right ventricle can't move into the pericardial space, so the extra volume pushes the interventricular septum toward the left. This leads to a reduction in left ventricular diastolic volume, a lower stroke volume, and a drop in systolic blood pressure during inspiration. A decrease in the systolic pressure of greater than 10 millimeters of mercury is called pulsus paradoxus, and is a classic sign of cardiac tamponade. In tamponade, there's also trouble in the upper heart chambers. The atria can't distend enough to accommodate the venous blood returning to the heart. That blood will have nowhere to go but back into the veins. And that's why you'll typically see distended jugular veins when you look at the neck of a person with cardiac tamponade. This sign is actually part of a triad of symptoms called Beck's triad, which is distended neck veins, hypotension, and distant heart sounds on auscultation. Although not part of the triad, tachycardia as well as coughing can also develop. People with tamponade might also have dyspnea, or difficulty breathing, as well as weakness and lightheadedness. If it gets severe enough, the heart can ultimately start getting ischemic, or low on blood, which causes it to stop beating. And this situation requires immediate drainage of pericardial fluid. A diagnosis of cardiac tamponade often starts with an ECG. Classic findings include tachycardia, a low QRS complex voltage, and electrical alternans, which is when the QRS complexes have different heights. Echocardiography can show the excess pericardial fluid, as well as the heart swinging inside the pericardial cavity. Cardiac catheterization measures the pressure inside the cardiac chambers. In the case of tamponade, the pressure in all four chambers is equal. Treatment of cardiac tamponade in the acute setting is pericardiocentesis, and that's where a needle is inserted into the pericardium to drain the excess pericardial fluid. After that, the underlying disease is typically addressed. Alright, as a quick recap, cardiac tamponade is a collection of fluid inside the pericardium that puts pressure on the heart and affects its function. It frequently presents with Beck's triad, which is hypotension, distended neck veins, and distant heart sounds on auscultation. Treatment of cardiac tamponade requires an immediate pericardiocentesis, as well as management of the underlying condition.
With pericarditis, peri means around, card means the heart, and itis means inflamed. So pericarditis means the pericardial layer of tissue that covers the heart has inflammation. People who develop pericarditis are also at risk of developing a pericardial effusion. That's when the inflammation causes fluid to accumulate around the heart. The pericardium is a pouch or cavity that the heart sits inside of. The outer layer of this pouch is the fibrous pericardium, and it helps keep the heart in place within the chest cavity. The inner layer of the pouch is the serous pericardium that includes the pericardial cavity and is filled with a small amount of fluid that lets the heart slip around as it beats. The cells of the serous pericardium secrete and reabsorb the fluid, so usually there's no more than 50 milliliters of fluid in the pericardial cavity at one time. That's about as much as a shot glass. Now, the cause of acute pericarditis is usually idiopathic, meaning that we don't know what causes it. Most of these are thought to be related to viral infections, like Coxsackie B virus. Another cause is Dressler syndrome, which occurs several weeks after a myocardial infarction, or heart attack. Basically, when heart cells die in a myocardial infarction, it leads to massive inflammation that also involves the serous pericardium. Another cause of pericarditis, called uremic pericarditis, is when blood levels of urea, a nitrogen waste product, get really high due to kidney problems. The high levels of urea irritate the serous pericardium, making it secrete a thick pericardial fluid that's full of fibrin strands and white blood cells. This gives the wall of the serous pericardium a buttered bread appearance. Pericarditis can also be seen in autoimmune diseases like rheumatoid arthritis, scleroderma, or systemic lupus erythematosus, because the immune system attacks its own tissues, including the pericardium. Other causes of pericarditis include cancers like lung cancer and lymphoma, radiation therapy in the chest, and even medications like penicillin and certain anticonvulsants. Regardless of the cause, inflammation in the pericardium means that fluid as well as immune cells start moving from tiny blood vessels in the fibrous and serous pericardium into the tissue or interstitium of those layers, making the layer itself a bit thicker and more boggy. Think of how a piece of dry, flat pasta gets cooked and thickens up as it soaks up fluid. Now, a pericardial effusion can also develop. That's when pericardial fluid begins to pool in the pericardial space, because the serous pericardium can't remove it as quickly as it comes in. If a lot of fluid starts to collect in the pericardial space, in other words, if that pericardial effusion gets really big, then it can start putting pressure on the heart itself, preventing it from fully stretching out or relaxing between contractions. This can lead to tamponade physiology, which is when the cardiac chambers can't fill with blood properly, causing a decrease in cardiac output, which can be a medical emergency. When the inflammation persists, immune cells can initiate fibrosis of the serous pericardium, which can produce an inelastic shell around the heart, making it hard for the ventricles to expand. It's like the heart is wrapped by a boa constrictor. This is called constrictive pericarditis. Over time, it becomes harder for the heart to relax or expand, and the stroke volume, the amount of blood the heart squirts out with each heartbeat, goes down, and to compensate, the heart rate goes up. This is similar to tamponade physiology, but happens more gradually and is a result of a change in the composition of the serous pericardium rather than a fluid collection around the serous pericardium. The main symptoms of pericarditis are fever and chest pain that worsens with deep breathing, but improves with sitting up and leaning forward. Larger pericardial effusions, those over 100 milliliters of fluid, can cause diminished heart sounds and can even diminish cardiac output, leading to shortness of breath, low blood pressure, and lightheadedness. There are a few ways to diagnose pericarditis and pericardial effusions. First, when the thickened layers of the pericardium rub up against each other, it creates a friction rub which can be heard on auscultation. It sounds like two pieces of leather rubbing against each other. Next, on an electrocardiogram, there are a few changes that you can expect to see. In the first couple of days to weeks, there can be ST segment elevations and PR segment depressions. After that, the T waves tend to flatten and then becomes inverted over a few weeks, and then eventually the ECG returns back to normal. On an ECG, pericardial effusions, especially large ones, can show low QRS complex voltage, or electrical alternans, which is where the QRS complexes have different heights, as a result of the heart swinging back and forth in a pool of pericardial fluid. On an X-ray of a heart with a large pericardial effusion, you can see a silhouette that pools to the bottom of the heart and gives a classic water bottle sign. On an echocardiogram, a pericardial effusion makes the heart look like it's dancing within the pericardium, whereas constrictive pericarditis shows the stiff serous pericardium restricting the heart's movement. In terms of treatment, the main goal is to relieve pain with analgesic medication and to treat the underlying cause of inflammation. Colchicine, a medication that inhibits neutrophil migration, is also used to decrease the likelihood of recurrent pericarditis. If there's a severe pericardial effusion, a pericardiocentesis can be done by inserting a needle into the pericardial cavity and draining the excess fluid. Constrictive pericarditis may require pericardiectomy, which is a surgical removal of the pericardium. Alright, as a quick recap, acute pericarditis is usually caused by idiopathic causes, viruses, or after a myocardial infarction. It usually results in a friction rub as well as ECG changes like ST elevation and PR depression, followed by T-wave flattening and inversion. Pericardial effusions typically lead to low QRS voltages or electrical alternans and can be seen on an echocardiogram. Constrictive pericarditis typically results from fibrin deposition in the serous pericardium, and it prevents the heart from fully relaxing.